Neisseria and Moraxella. So, patient 18-year-old sexually active college student on a women's gymnastics team. Pain, redness, and swelling of both wrist joints and the left elbow. Patient's history: participated in casual unprotected sexual intercourse with 3 or 4 men during the past 4 months. Patient denied any vaginal discharge or abdominal pain, but recalled having had a rash recently on both her arms. The sample was an aspirate from the left wrist, sent to the lab for culture and gram stain. Direct gram stain smear results: many polymorphonuclear white blood cells, rare intracellular and extracellular gram-negative diplococci seen. Growth at 24 hours on chocolate agar, many small tan colonies. Sheep blood agar, no growth. CDC anaerobic blood agar, no growth. And McConkey agar, no growth. Next step: the organism was identified according to routine laboratory protocol. So the morphologically and biochemically similar Neisseria species and Moraxella cataralis. The pathogenic Neisseria species would be Neisseria gonorrhoeae, Neisseria meningitidis, and Moraxella cataralis. So this is a good flowchart that kind of separates out those different species based on some of their biochemical reactions. So members of the Neisseriaceae family include Neisseria, Kingella, Eikenella, Simonella, Elisiella, and several others. Many Neisseria species have optimal growth in a humid atmosphere. They grow as gram-negative diplococci and cytochrome oxidase and catalase positive. So oxidase positive, catalase positive, gram-negative diplococci. The exceptions are listed here. Again, they list a lot of different species just so you have exposure, but the main ones that you are responsible for knowing about are the ones that we're going to be going through here, those 3 pathogenic species from this slide here: gonorrhoeae, meningitidis, and then Moraxella cataralis. Many Neisseria species are capnophilic, requiring carbon dioxide for growth, with optimal growth in a humid atmosphere. If alternative electron acceptors or nitrates are present, organisms can grow anaerobically. Natural habitat: the mucous membranes of respiratory and urogenital tracts. So this is a list of some of the pathogens and opportunistic pathogens. Clinical significance: they exist as usual biota in the upper respiratory and urogenital tracts, meaning most isolates are considered opportunistic pathogens. N. meningitidis can be a commensal inhabitant in carriers. N. gonorrhoeae, often called the gonococci, is always pathogenic when present. N. meningitidis, or the meningococci, may be present as a commensal inhabitant of the upper respiratory tract of carriers and may become an opportunistic invasive pathogen. Commensal means that it simply just exists without causing harm or benefit. N. gonorrhoeae and N. meningitidis are fastidious. Fastidious means they're tough to grow. They require enriched medium or extra nutrients for optimal recovery. They also require iron for growth. Not all fastidious organisms do, but these two do. So they both compete with their human host by binding human transferrin to specific surface receptors. The primary reason these microorganisms are strict human pathogens. So virulence factors, receptors for human transferrin, allow it to compete for iron. Capsule: so N. meningitidis has a capsule that prevents phagocytosis. And then there's cell membrane proteins that provide antigenic variation and causes the production of useless antibodies. Binds to the pathogen and prevent binding of the effective antibodies. So this is just a diagram of the cell structure of pathogenic Neisseria. So we've got the capsule, the pili are important, which we'll talk about in a little bit. Then there's lipo-oligosaccharide, LOS, which is an endotoxin, and that's unique from lipopolysaccharide, LPS. So the pili, there's 5 distinct colony types. You don't need to know what those are, but they function to evade the immune system. They help it attach to the host tissues, prevent phagocytosis, and they aid in the exchange of genetic material from cell to cell. So some of these pili can grow really long and insert into neighboring cells. And then they can copy certain portions of DNA and they can transfer that DNA from one cell to the next. This may be beneficial in transferring like antibiotic resistance genes. So if one organism has the antibiotic resistance gene, they can make copies of it and start handing it out to all of their friends because there's safety in numbers. So if they want to survive as an organism, they have to be able to combat antibiotics. For Neisseria gonorrhoeae, humans are the only natural host. Gonorrhea, meaning flow of seed, when urethral discharge was mistaken for semen. Also called clap from the French word for brothel, clapoir. It's a reportable disease. Most commonly transmitted by sexual contact. Primary reservoir would be asymptomatic carriers. National reportable disease. Confirmed cases must be reported to the state health laboratories. Highest rates of infection, men and women between ages 20 and 24. Incubation period is 2 to 7 days. It's transmitted only by intimate sexual contact. Asymptomatic gonococcal infection is uncommon in men. 90% of infected men show symptoms of acute infection. Symptoms would be dysuria, urethral discharge. Complications would be epididymitis, or inflammation of the small coiled tube of the testicle. Prostatitis, inflammation of the prostate gland. Clinical infections in women, as many as 50% are asymptomatic. Endocervix is most common site of infection. Symptoms, if they have symptoms, are dysuria, cervical discharge, and lower abdominal pain. Complications include pelvic inflammatory disease, sterility, ectopic pregnancy, and perihepitis, or hepatitis. Hepa is referring to the liver. Itis is inflammation. So hepat, H-E-P-A-T, liver, itis, inflammation. Peri means to surround something. So swelling or inflammation around the liver. Bloodborne dissemination. So less than 1% of infections can transmit through the blood or disseminate, transfer deep into the blood. Fever, intermittent bacteremia, and rash on the extremities may be present, mostly from arginine, hypoxanine, and uracil strains affecting women. Blood culture medium containing sodium polyanthal sulfonate, SPS, inhibits gonorrhea, so you use gelatin to neutralize the effects of SPS. Bloodborne dissemination, so gonococcal arthritis is possible. The gonorrhea can travel to the joints and can infect joint fluid. Purulent arthritis, result of disseminated gonococcal bacteremia. Extragenital infections, oropharyngeal infections, and pharyngitis. Anorectal infections are most common in men who have sex with men. 30 to 60% of women with genital infection can get anorectal infection. Rectal pain or bloody stools is possible. Many infections are asymptomatic or have nonspecific symptoms. Diseases in newborns. Ophthalmia neonatorium occurs during vaginal delivery through an infected birth canal. So as the baby's coming through the vaginal birth canal, if not treated immediately, newborn blindness can occur. This is why today in the United States, every infant that comes through the birth canal must be treated with these eye drops at birth, generally erythromycin. This is a requirement by law. Of course, the mother would have to be delivering the baby in a healthcare facility. So if they happen to have a home delivery or a delivery elsewhere, those drops may be missed. Clinical specimens, genital sites, the urethra in males. Collect purulent discharge. If no discharge, insert the swab 2 centimeters into the urethra and slowly rotate. And the endocervix in females. A rectal culture, insert the swab 4 to 5 centimeters into the anal canal. Oropharyngeal, eye, blood, joint fluids. When possible, the laboratory must be notified when a sample for gonococcal recovery is expected. Preferred swabs would be Dacron or Rayon. Calcium alginate and cotton swabs are inhibitory to gonorrhea. Direct plating of specimen to gonococcal selective media gives optimal results. There are transport systems available that contain selective media and a CO2 capnophilic atmosphere. The specimen is rolled in a Z pattern on the medium, the plate within 6 hours if using the Amy's transport medium. So this is a picture of that JEMBEC plate. So for urogenital specimens, you perform direct gram stain. Pharyngeal specimens, you direct gram stain is not recommended because the commensal Neisseria species can be present. So urogenital, especially from a male, if you see the microscopic morphology that's consistent with gonorrhea, we can almost assume that it is gonorrhea. But there are in respiratory specimens, there's a lot of other organisms that look like it. So it's difficult to just look at it under the microscope and say, yep, this is gonorrhea. So microscopic morphology, urethral discharge of a symptomatic male, kidney bean-shaped gram-negative intracellular diplococci. When present, 89% likely to be a gonococcal infection. There's avirulent forms lacking pili, extracellular gram-negative diplococci. In women, 50 to 70% correlation of direct gram stain with culture, but there are commensal vaginal microbiota that resemble gonococci. Discharge in symptomatic women, gram stain may be helpful, but culture is necessary for confirmation. Gram stain smear with more than 5 polymorphonuclear neutrophils per field with no bacteria suggests that it's not gonorrhea. So here you can see male urethral discharge showing intracellular and extracellular gram-negative diplococci. So you can see the gram-negative diplococci next to each other. And then the direct smear with more than 5 polymorphonuclear neutrophils per field, but not bacteria. This is suggested of not being gonorrhea. Inoculate the selective medium to prevent the overgrowth of normal biota. Incubate it 35C and 3% to 5% CO2. And then here's some different media that's used. Thayer-Martin or modified Thayer-Martin on the qualifying exam. It may ask you questions about, or it very well could ask you questions about what type of selective media would be used to isolate gonorrhea. Or it may say gram-negative diplococci isolated from a male urethral specimen. The man is complaining of dysuria and pain in the lower abdomen. And which medium would you use to grow this potential pathogen? And it would be looking for you to select MTM or just Thayer-Martin. And this is what it looks like on MTM. Gram stain must be performed on suspected isolates to verify the appearance of gram-negative diplococci. Small gram-negative bacilli, occasionally growing on gonococcal selective media, such as Shigella and Acinetobacter, may be found. So to differentiate those from the gram-negative diplococci, we would typically streak the organism to a plate with a 10-unit penicillin disc. After incubation, we stain the growth at the edge of the zone of inhibition and examine the morphology. So here, we would streak it, we would put a penicillin disc on there, and then we would collect bacteria from the edge of the zone. And if we see those gram-negative diplococci, we can safely assume that it is gonorrhea. Otherwise, we would see these other morphologies here, and then we would know that it's not. Oxidase test, you can either test this on filter paper or on the direct plate method. This is the filter paper disc. This is a positive result for oxidase. This is a negative result. Or you can put it directly on the plate. And here you can see positive versus an area that was untreated. Other oxidase positive gram-negative diplococci can grow on selective medium from the same sites. And examples are listed there. Further tests are required to differentiate these organisms. Carbohydrate utilization is one of those tests. So cysteine trypticase agar, or CTA, contains 1% of a single carbohydrate, glucose, maltose, lactose, or sucrose. Phenol red is the pH indicator, and it's red 24 to 72 hours. Yellow color is a positive result. So N. gonorrhoeae is only positive for glucose. N. meningitis is positive for glucose and maltose. N. lactamica is positive for glucose, maltose, and lactose. On a test for this course or in the qualifying exam, you will have to know the sugar reactions of these three species and what they would be positive for. So gonorrhoeae, glucose, meningitis, glucose and maltose, lactamica, glucose, maltose, and lactose. Lactamica is the only one, the only Neisseria species that is positive for lactose. NAT, or nucleic acid amplification tests. A lot of times we combine the test for gonorrhea and chlamydia into one test system. But this is a FDA-approved test method for the identification of Neisseria species. There's multi-test methods that are available too, like the microscan panels, where we have Neisseria and Haemophilus together on one panel. That's a good use of biochemical tests to distinguish. We also have the MALDI system, so the MALDI can identify the different species. And here are some characteristics of significant species of Neisseria, Moraxella, and Kingella. So, as I was mentioning previously, gonorrhea is positive for glucose, and meningitis is positive for glucose and maltose, and lactamica is positive for glucose, maltose, and lactose. Moraxella is negative for all of those. So those nucleic acid amplification tests are the preferred assay for the detection of gonorrhea, because then we don't have to grow it and we don't have to have large quantities of it in the laboratory. It's extremely sensitive and don't require viable organisms. The best sample comes from men. The first morning voided urine is equivalent or better than urethral swabs for testing. The best sample for women would be vaginal swabs, have been demonstrated to be sensitive as cervical swabs. First morning voided urine samples can be used for screening, with the caveat that up to 10% fewer cases are detected compared with vaginal or cervical swabs. NAT is not recommended. In cases of child sexual assault involving boys in an extragenital infections, rectal, oropharyngeal, or prepubescent girls, or as a test of cure. The genetic material of these organisms will be left behind, so we can't just do a NAT test to see, oh, did the antibiotic treatment work or not, because the genetic material will stay in the area for quite some time, even if the organism is dead and gone and successfully treated. So the advantages of the nucleic acid assays would be increased sensitivity, I believe that should say specificity and ability to test with non-invasive first morning urine specimens. Disadvantages: not approved for use as a test of cure, not approved for pharyngeal or rectal specimens, and do not allow for the recovery of an organism to be used for susceptibility testing. Historically, in the United States, almost all strains of N. gonorrhoeae were susceptible to penicillin. Then, in 1976, along came the first plasmid-mediated penicillinase-producing strains. Mechanism: an organism acquires a plasmid with genes for beta-lactamase production. N. gonorrhoeae can exhibit chromosome-mediated penicillin resistance, and these strains are beta-lactamase negative. N. gonorrhoeae also exhibits plasmid-mediated resistance and chromosomal-mediated resistance to tetracycline, spectinomycin, and fluoroquinolones, such as ciprofloxacin. Because of concerns over the development of antimicrobial resistance, the CDC developed the Gonococcal Isolate Surveillance Project. 2020 treatment guidelines for gonococcal infection recommend single 500 milligram intramuscular dose of ceftriaxone for uncomplicated gonorrhea. If chlamydial infection cannot be excluded, oral doxycycline. should also be administered. So switching gears to N. meningitis. So we just covered gonorrhea. Now we're going to talk about the meningococcus that causes meningitis. This is found only in humans, and it may be a commensal or an invasive pathogen. It's an important etiological agent of epidemic meningitis and meningococcemia, rarely associated with pneumonia, purulent arthritis, or endophthalmitis. Has been recovered from urogenital and rectal sites. N. meningitis is found on mucosal surfaces like the nasopharynx and oropharynx in approximately 30% of the population. It's transmitted by close contact with respiratory droplet secretions from carrier to a new host. Only a few colonized hosts develop meningococcal disease. The highest incidence is in infants and adolescents. Populations at risk: asplenic patients. Asplenic means the absence of a spleen. Anytime you put the letter A in front of something, that's usually the absence of. So asplenic, they don't have a spleen. Individuals with complement deficiencies. Populations at serious risk or risk of serious disease are smokers, people exposed to smoke, and individuals with concurrent respiratory tract viral infection. Transmission of meningococcus occurs in crowded living conditions like military recruits, college students who live in dorms or tight apartments. Meningococcal disease is uncommon in developed nations. There's an area in Africa known as meningitis belt, frequently experiences epidemics during the hot and dry season. Incubation period is 1 to 10 days by colonizing mucosa. A small number have bacteria enter the bloodstream and potentially the central nervous system. Leads to septicemia and or meningitis. The characterization of meningitis includes frontal headache, stiff neck, confusion, photophobia, nausea and vomiting, sometimes fever, and purulent spinal fluid. So typically CSF should be clear. If you see that it's cloudy, you could suspect meningitis. Meningococcemia, appearance of skin petechiae, purpura, tachycardia, hypotension, and thrombosis is common. So you see like discoloration of the skin, raised colored, sometimes it's dark purple or red in color. Fulminant disease, hemorrhage in the adrenal glands. Other complications include arthritis, pericarditis, pneumonia, conjunctivitis, and urethritis. So arthritis is referring to inflammation of the joints. Pericarditis. Peri means to surround something. Carditis refers to the heart, so surrounding the heart. Pneumonia, that's a deep lung infection. Conjunctiva is the membrane that surrounds the eye, so conjunctivitis would be an eye infection. And urethritis, that's infection or inflammation of the urethra. So this is meningococcemia in an infant hemorrhaging in Waterhouse-Fridtjof syndrome. Specimen collection and transport. Specimens of choice would be cerebrospinal fluid, blood. Because N. meningitis is inhibited by SPS, you need to use non-SPS containing blood collection system. Nasopharyngeal swabs or aspirates, joint fluids, and less commonly sputum and urogenital sites. Gram-stain smears from specimens such as CSF. Meningococci appear as intracellular and extracellular gram-negative diplococci. The concentration of CSF can improve detection on direct exam. So at least 1 ml of CSF should be centrifuged at 1,000 times G for 10 minutes, and then you look at the sediment, because sometimes the microorganisms can be so dilute in concentration in the CSF. We want to make sure that we're not missing anything. So standard practice is usually as soon as you receive a CSF specimen, you would centrifuge it. There's also cytocentrifugation, where you set up an apparatus that will spin the sediment from a sample directly onto a microscope slide, and then you can stain that slide directly and look at it. So here you can see a direct gram stain smear of CSF and the intracellular and extracellular gram-negative diplococci. This is a public health concern. So if this is reported, you do need to notify the state health department. It grows on sheep blood agar and chocolate agar. Incubated 35C in the presence of CO2 and examine the plates daily for 72 hours. Identification is based on colony morphology, microscopic morphology, and the oxidase test, and we can also throw it on the MALDI for identification or the microscan. Colony morphology, medium-sized gray convex encapsulated strains are mucoid. Blood underneath the colonies tend to have green tinge. On selective agars, colonies are colorless to gray, convex, and smooth. So this is what it looks like on a chocolate agar plate on the left and a blood agar plate on the right. Oxidase positive. Definitive diagnosis can be made by carbohydrate methods, chromogenic enzyme tests, multi-test assays like the microscan panel, or the MALDI. There were, in 2000, 2 cases of laboratory-acquired meningococcal disease. Both victims were clinical microbiologists who examined plates, performed gram stains, subcultured, or performed slide agglutination serotyping on patient isolates on the open bench. So now the CDC recommends work under a BSL-2 cabinet, biosafety cabinet, to prevent future such disease. For suspected meningococcal disease, extended spectrum cephalosporin, cefotaxime or ceftriaxone. For confirmed cases, definitive treatment with penicillin G, ampicillin, or extended spectrum cephalosporin is recommended. Routine susceptibility testing was not previously recommended, but recent reports of beta-lactamase producing and meningitis serogroup Y cases in the United States have prompted a recommendation that susceptibility to penicillin be determined before administering penicillin. The reason for this is we need to know that the treatment is going to work. When we have something like this significant of meningitis, we, number one, want to isolate the patient, and we want to make sure that this isn't going to spread further into the community because it is highly contagious. But we also want to know that the patient that we're treating is going to actually recover from this and be treated from this. So we do that susceptibility testing to ensure that we don't have an even bigger public health concern, but also to ensure that the patient at hand is going to be treated. Close contacts of patients with invasive meningococcal disease are at increased risk of contracting this infection. Chemoprophylaxis with rifampin, ceftriaxone, ciprofloxacin is recommended for contacts. Chemoprophylaxis. Prophylaxis is talking about the steps that you would take to prevent infection after exposure. So you don't know if you have the infection or not, but you're going to take some steps to prevent the infection from happening or the infection from getting worse. Chemo is referring to chemical. So chemoprophylaxis is the use of drugs or chemicals to prevent the spread or the increase in severity of a disease. Azithromycin can be used as a first-line chemoprophylactic agent in instances where ciprofloxacin resistance is a problem. Chemoprophylaxis is not recommended for asymptomatic carriers. And meningitis vaccine. So there are vaccines that exist. Routine vaccination at 11 to 12 years of age, and then a booster dose at 16 years of age. If not previously vaccinated, individuals entering high school and college, freshmen living in dormitories should receive the vaccine. Military personnel should receive the vaccine. So vaccines are also recommended, as I mentioned, for military recruits, asplenic patients older than 2 years of age, laboratory scientists who work with end meningitis, and other high-risk groups. Moraxella catarrhalis. So this is in the family Moraxellaceae, contains 3 genera, Moraxella, Acinetobacter, and Psychrobacter. Normal commensal of the respiratory tract. So this one's normally found inside the respiratory tract, usually doesn't cause harm or benefit. Important opportunistic pathogen, isolated only from humans. Upper respiratory tract infection in otherwise healthy children and older adults. lower respiratory tract infections, especially in patients with COPD or chronic obstructive pulmonary disease. Predisposing factors would be advanced age, immunodeficiency, neutropenia, or chronic debilitating disease. Considered as the third most common cause in children of acute otitis media, or an ear infection, sinusitis, or a sinus infection. Rare life-threatening symptomatic diseases such as endocarditis, meningitis, and bacterial tracheitis. Severe infections may occur in immunocompromised hosts and hospital outbreaks. Most isolates produce beta-lactamase, thus they're resistant to ampicillin and amoxicillin. Antimicrobial agents used include amoxicillin clavulanic acid, also known as Augmentin. Actually, my son just recovered from a strep throat infection. Then he developed a sinus, an ear, and eye infection, and they treated him with Augmentin even after he completed his full course of amoxicillin. So this antimicrobial agent, because M. cataralis is resistant, was used to treat my son. Extended spectrum cephalosporins, azithromycin, quinolones, and trimethoprim sulfamethoxazole. Specimen collection, middle ear effusion, nasopharynx, sinus apparatus, sputum, bronchial aspirates. Even though we should culture, determine the identity of the microorganism, and determine antibiotic susceptibility for different types of antibiotics, typically we don't. Especially with children, we go with signs and symptoms and treat with an antibiotic and hope it gets better. Culture characteristics: grows on SBA and chocolate agar, smooth, opaque, gray to white colonies. The colony is referred to as resembling a hockey puck. Other colonies resemble a wagon wheel. Optimal growth is 35 to 37 degrees Celsius. It is inhibited on gonococcal selective media by colistin, but some resistant strains may grow. Identification would be that it's oxidase and catalase positive, asaccharolytic. So I mentioned earlier how the different types of Neisseria will be able to utilize different types of sugars. This one is asaccharolytic. So there's the absence of the lysis, or the ability to break down saccharides or sugars, asaccharolytic. With all of these big terms, you can always break them down into little pieces and kind of deduce the definition. And being able to do that on the qualifying exam is going to be so important. So if you practice that now, it's really going to help you in the future. Just see those big words and try to break apart which components of it kind of are familiar, and you can eventually deduce the definition that way. Positive DNase and butyrate esterase reactions and MALDI mass spectrometry provides rapid and accurate identification. So this is a direct smear and culture. So what it would look like on culture medium. And then you can review the points to remember.